So we're going to talk a little bit about empathy and the role of emotional contagion, specifically of how it relates to healthcare delivery and health professionals, as well as health profession students. First off, let me give you a little background on me. Yes, as Dr. Kelly said, I was at University of Delaware. I am now at the Arizona State University, but I started over at Emory University. That's where I did my undergrad work. That's in Atlanta, Georgia. And I majored in both psych and soc. I was really interested in both the kind of micro elements, the micro of psych, and then also some of the micro meso, and then some of the macro, kind of larger stuff that soc provided. There was a big break between when I was at Emory and when I went to East Carolina. And the reason for that is because I had zero intention of going back to school. When I was an undergrad, I didn't do so hot. I focused a lot on my friends and social activities and sports and things like that. And I enjoyed school a lot, but at the same time, I was kind of disheartened. A lot of the instructors at the time were utilizing their own books and their own articles to really teach subject matter, and I got kind of upset with that. And so one of the things that I would do a lot would write papers against their books or against their theories or against stuff, and that wasn't, you can imagine, didn't go over very well. And so I didn't do great, but I really did enjoy the idea of going back. So I took some time off, and I actually, during that time, I worked at ESPN Zone, which is, I think it's now defunct, but it was a bar slash arcade slash sports oriented place. I'm sure you've heard of it. And so that's what I did for about 2 years. About a year into it, I realized that there were things that I really enjoyed, and that was kind of digging in the crates for answers. I really enjoyed kind of doing research on things, kind of finding the roots of understanding particular things. And I also like kind of, for lack of a better phrase, kind of being on stage and talking to people in that way. And I thought a way of engaging both of those was to actually go and get a PhD, but I wanted to make sure, and be a professor, but I wanted to make sure that was actually a good route for me. And then also, I didn't know if like school and I was a good combo. So I thought the best route was really to go for my master's to see if that was the way to go. And I had the privilege of going to East Carolina University. And I say that because, East Carolina may not get the best rap in terms of academics. But for me, it was one of the most fascinating and fantastic scholarly experiences I've ever had, and great social experience too. The sociology department there was really progressive and really into engaging students, graduate students, on research. And so a majority of the kind of fundamentals that I learned it really came from that department. And then I went back to Emory to kind of, because I had a chip on my shoulder and said, I got to show you all that I know what I'm doing. And so went back there for my PhD and worked with some great people in the social psych department and the sociology department in general. Ended up at University of Delaware in 2009 after my dissertation. And like Dr. Kelly said, that's where I had the privilege of having great students like Dr. Kelly in there, who were very interested in various aspects of health and healthcare delivery, as well as gender and race, and how all of that intertwines and kind of impacts patient experiences, as well as providers' experiences, and health profession students as well. So it was a really great experience to be able to teach and lead in that way. Had a great time there, but the desert came calling. And so now I'm the director of a center that deals with interprofessional education. I'm sure most of you who are on this know what interprofessional education is. It's where we take various health professionals and health profession students and have them learn with, from, and about each other so that we can promote team-based collaborative care. And so my job is to really continue the research and the program development to help advance those types of attributes. So elements and practices and behaviors and values that we can embed in the healthcare workforce of the future to be better team players. And as a sociologist, there's only a couple of us kind of playing in this sandbox. And I tell you, we bring a whole new level to that particular field. So much so that the National Center for Interprofessional Education and Practice, the Nexus they call it, has actually gone ahead and greenlit an initiative in advancing the social science in and of interprofessional education. So, you know, we're not only have we knocked on the door, but we're kind of kicking it in now. And there's a whole level of stuff going on that's just such fantastic kind of new ways. So really exciting time to be in interprofessional world and do the work that we do. So if anybody has any more questions about that, we can talk about it at the end. So my research, how do health profession students learn to be health professionals? That's basically the fundamentals of how I do my work, or kind of where my work lies. I'm really interested in pro-social, what we call pro-social and other oriented attributes like empathy, like humility, and other kind of attributes that we engage others with that are less about me and more about we. So how can we level the playing field where not only are health professionals and patients kind of engaging on a kind of a more equal level, but also how can we do this with health professionals and other health professionals, as well as health profession students and other health profession students? Because we all know there's this, make-believe occupational status hierarchy that exists. You know, our job within the interprofessional field is to try to break that down so that we can actually have people see each other on the same field to some extent, to help advance that teamness. That's where my work comes in. And where it started was really, this notion of empathy and emotional contagion, which I'll talk about today, really stemmed from my original work way back when at East Carolina and Emory on social support. I had done all this research on social support, how it worked within formal support groups for breast cancer survivors, and then informally in interpersonal connectivity, and realized that empathy played such a huge part. So, why do we do it? Why do we give of ourselves? Like, why are we this way where it doesn't seem beneficial? Why do we do this pro-social stuff that actually seems detrimental? And that really goes to all this notion of empathy and humility and emotional contagion that I'll talk about. So what is empathy? I personally and other scholars subscribe to kind of the overarching, more broader theories. And one specific overarching broader theory of empathy comes from Franz de Waal, who, oddly enough, was at Emory when I was there. I did not know that he did this stuff, nor did I know that that this would have been fantastic if I had a chance to interact with him. Just goes to show you sometimes don't even know what's available to you when you're around. He looks very sad there. So let me go ahead, and I have this other picture when he was younger. Maybe that's why I grew my mustache out. I'm not quite sure, but so he is the he brings up this notion of empathy in a very evolutionary, he's kind of a primatologist by nature, kind of an evolutionary way. So he's a professor of psychology at Emory and director of the Yerkes Primate Research Center. He frames empathy as an emotional and mental sensitivity to another state, another emotional state, from being affected by and sharing in this state to assessing the reasons for it and adopting the other's point of view. So really talking about empathy in this emotional and cognitive perspective. The issue that we run into with a lot of the empathy sandbox is this notion of whether it's emotional or cognitive, primarily one or the other, or some level of both. And one of the reasons, like I said, that kind of scholars subscribe to a more broader approach is really to engage that emotional and cognitive perspectives of empathy. Some definitions of empathy stress the sharing of emotions, whereas other definitions stress the capacity to put oneself into the other's shoes. The latter definitions are so top-down, however, that they disconnect empathy from its possible antecedents. We follow a bottom-up approach instead, adopting the broadest possible definition, including mere emotional sensitivity to others. And again, this kind of, I just give you a little bit of theoretical background as to kind of where we're coming from when we talk about empathy. This is one of the things, and Dr. Kelly may have seen this on my door in my office at UD. I had put this quote up on there early on, and I left it up there. It's one of my favorite quotes about empathy in general. We're pre-programmed to reach out. Empathy is an automated response over which we have limited control. We can suppress it, mentally block it, or fail to act on it. But except for a tiny percentage of humans known as psychopaths, no one is emotionally immune to another situation. The fundamental yet rarely asked question is, why natural selection designed our brains so that we're in tune with our fellow human beings, feel distress at their distress and pleasure at their pleasure. If exploitation of others were all that mattered, evolution should never have gotten into the empathy business. And so this notion of the evolutionary resilience of empathy, if it was detrimental, then it would have been beaten out of us a long time ago. Yet we still have this kind of innate involuntary nature associated with empathy. And so again, this is one of my favorite notions of understanding why it's important and why we have it. So for de Waal and for this kind of overarching notion of empathy, allows one to quickly and automatically relate to the emotional states of other. And we'll talk about how that happens in a second regarding emotional contagion. It's essential for regulation of social interactions and coordinated activity, kind of talking about the evolutionary nature of it. The cognition in this model is the perspective taking, you could say, is important, but it's actually secondary to a fundamental emotional connectivity to others that we have. Humans must be equipped biologically to function effectively in many social situations without undue reliance on cognitive processes. How cool, like for me, how cool is that? Like we have to exist as humans. We wouldn't have made it this far if we had to be all up here all the time. Like we would have just burned out. Like de Waal and others like paint this picture of how the nature of emotional connectivity is so essential. It has allowed us to thrive. Oh, I'm on a timer here, I apologize. It's allowed us to thrive in our social situations and through time. Like that connectivity is essential. I love it. So this essential for regulation of social interactions, de Waal and a lot of others who deal with this work talk about empathy-inducing signals and the idea of how our connectivity to others, whether we're talking about primates, we're talking about humans or other species, right? We talk about this ability to signal to others somewhat, non-verbally, in a way to show them that there's distress or to show them that something is happening to us. We give them these cues, these physiological cues that something is happening that they need to be aware of. How cool is, like, how amazing is that in terms of how we do that? So there are distress vocalizations that you probably heard birds do, and even a number of animals do it. We do it, we scream, we yell, right? But also the value in understanding emotional states through nonverbal cues. Oh, my timer. So I had this great little GIF here, right? So my timer blew it. But anyway, it blows my mind. Like this whole thing just blows me away. I love talking about this idea of how amazing we are in terms of our connectivity and why we don't embrace it and why we don't look to it more. And so de Waal, in his kind of Russian doll model, which is another reason why I love this particular theory, is because it's very simple. And the way it's described is very simple. And so you can see that the way it's layered in terms of the core elements are that PAM, right? That state matching and the notion of emotional contagion. And we're going to talk about that in 1 second. And then also there's the higher levels of sympathetic concern and empathic perspective taking, those higher cognitive levels as we move forward. But the core is that emotional contagion. That's the key elements. So what is emotional contagion, right? And this is something that doesn't get a ton of talking about. And I'm really surprised because it is such a unique phenomenon. So just like a cold or even a yawn, emotions are contagious, right? You can catch them from others. You can catch others like emotional states just by seeing them. I'm sure this has happened. You just haven't really either paid too much attention to it or you've noticed it when it's kind of its most full blown, right? So emotional contagion is the sharing or taking on of the emotional states of another person to some extent, right? It's not necessarily the same emotion. It's some element, some form of it, some level of it. It's not necessarily the same, right? You can't feel the same emotion as somebody else, but you can feel if someone's sad and they're showing you sadness, right? You'll feel a level of sadness, some degree of sadness. Maybe not their degree, but some degree of sadness just by witnessing it in someone else. That's insane. So I argue that it's like a superpower. I don't know if this is the video you were talking about. I gave a TEDx talk on the superpower of emotional contagion. I put the link in there. I'm not going to show it to you here, but if you have time, check it out. To me, it's just one of the most unique and kind of incredible kind of abilities. And it's innate, it's involuntary. It's something that we can't control. It just kind of happens. And you probably have experienced of it to some extent. Like I said, you've probably seen it with movies or with TV shows or with friends or family, or even people walking down the street that maybe are expressing some degree of sadness, and you can tell it, and you can feel a little bit of it. And one of the things that we really try to teach for our health profession students, which I'll talk about in a little bit, is to embrace that, to not suppress that. And I know that sounds like it could be overwhelming, but I'm going to tell you how we do it and kind of ways in which we work with it. So what we say, since it's innate, right, you really shouldn't be suppressing this. And we talk about how through socialization processes, a lot of health profession programs teach that emotions are bad, right? We shouldn't be sharing the emotional states of our patients or of our colleagues, because we'll become overwhelmed. We can't engage it with patient after patient after patient. It'll kill us. It'll lead to burnout and emotional exhaustion. And I'll say, sure, not incorrect. However, what if we turn into the skid? What if we embrace this notion of emotional contagion, right? And the larger degree of empathy as it relates to the larger degree of empathy. And we actually learn how to hone those skills, how we learn to kind of strengthen those muscles, to build like an empathic resilience. So we know that between the self and the other, how this actually works. And we can utilize other emotional states as data to further help our patients, to further help our colleagues, to further help our friends. If we stop seeing it so much as a detriment, like it would have been beaten out of us a long time ago if we didn't need it. Yet we're shown that we have it and stayed with us. So there's a reason for it. Why don't we use it? Why don't we use that superpower? So that's the kind of work that we do within my center now in terms of advancing that. So we're born with it. It's innate. It's going to be it's really hard and cost a lot in terms of emotional exhaustion, in terms of burnout, in terms of suppressing it if you tried to. So why don't we try to embrace it? Okay. So why do we care about empathy in general within the health professions? I'm sure all of you who are engaged with health profession stuff are totally have heard enough about empathy, right? And yeah, it's because studies have shown that patients who perceive their provider to be more empathic have higher satisfaction with their provider. They have higher rate of compliance. They have better physical and mental health outcomes. So it's good. It's a good thing, right? We make sure it helps bottom line. It helps reimbursement rates. It also leads to better health outcomes. That's great. Providers who have higher levels of empathy towards patients have higher job satisfaction, fewer malpractice suits, higher rates of reimbursement based upon the value-based model that we exist in the US in terms of reimbursements, lower rates of burnout, and higher rates of collaboration with colleagues. So it's good for healthcare providers as well in terms of their own job satisfaction, in terms of their own overall well-being. Now, there are some studies that show that higher levels of empathy do actually correlate with higher levels of burnout and emotional exhaustion, but there are others that say no. So they're both ways there. There's a little bit of a debate. But we'll also, for the sake of this argument, we say that, hey, it's good for well-being until proven otherwise. So the clinical perspective on empathy is very different than the general perspective. So I have a paper coming out. I just signed off on the proofs. Hopefully it's out soon. I'll make sure Dr. Kelly says it. This came from my dissertation. It's taken me 12 years to write because it's one of those things of like, it kind of kicks a hornet's nest, and I'm a little scared at how people are going to react to it. But sometimes you got to write papers like that just to get it going, right? Because you feel that you got to say it. The timer on this. So clinical empathy is very different than the general empathy sense. And the reason for that is because the clinical empathy term, or the concept of a clinical empathy, really focuses on the cognitive aspects of empathy, the perspective taking, the imagining, right? And keeps that emotional distance from provider to patient, keeps the emotions, emotions are bad, keeps them away, right? It really focuses on the cognitive, and all the stuff that's kind of in training and in the research is all about the clinical stuff. We got to be safe. We got to keep it. It's an intellectual skill, according to some of the scholars in that area. This maintains that overarching cultural understanding within healthcare and within medicine specifically, that emotional sharing is quote unquote bad, right? It can be detrimental. Emotions in general, especially others' emotions, are taxing or seen as taxing and clouding clinical judgment and reason, right? They can be overwhelming. They're detrimental. We don't want them, right? They can be like, the others' emotions can be like quicksand for providers to fall into and health profession students to fall into. This perspective extracts the natural human capacity of emotional sharing, empathy, emotional contagion from empathy, and says, don't do this, right? It's bad for you. Don't engage with it. And if you look at any of the ways in which empathy in the clinical realm is operationalized or measured, you'll see that they have extracted. any type of form of emotional sharing. And for a particular reason, for a number of reasons. And that this paper that I like to talk about comes out and talks about that. And emotional labor can lead to burnout in terms of trying to work with the emotions within the clinical site. All that level can lead to burnout. Also, the suppression of emotional contagion can lead to burnout. And then also this notion of not engaging with the patient or coming across inauthentically to patients can actually lead to distance and from the healthcare provider and the patient as well. So the argument is something's going on here. We're not doing the things. The system has been built and getting it's perfectly designed to get the results it gets. We're not really engaging with emotions. There's no wonder that we're not seeing a higher emotional resonance amongst providers and patients, because we're just not building a system that promotes that idea. So we argue, turn into the quicksand, right? Learn how to work within the quicksand, build that empathic resilience, right? Turn into the skid, turn into that emotional sharing, that emotional contagion skid, and utilize that in a way to become more authentically empathic with patients. And what do we mean by that? Well, how do we do that? We build our empathy muscles. So we do that through engaging, and what we mean by empathy muscles, emotional attunement and resonation, understanding and kind of being able to connect and understanding that you're sharing emotional states with others and resonating with that emotion. Affect recognition in terms of understanding what emotions look like. You'd be surprised at how challenging that can actually be. And understanding, being correct with emotional accuracy. Self and other awareness, being able to understand that what you're experiencing is just some extent of what the other is experiencing. It's not the same thing. Their emotional state is not your emotional state. And I'm no longer going to have timers on these things. Regulations of emotions, being able to understand how to regulate own emotional states in a positive way. Mental flexibility, observation, presence, listening, vulnerability, these types of things. These are things that we talk about in terms of empathy-related muscles. Can they be practiced? Can they be taught? Can they be honed? That's kind of the big debate in the literature always is, can these things be taught? Are they professional skills that can be taught, or are they also personal skills that need to be honed? And that's what we do within our center and what we're trying to build. And what we're building is a program called iTeam by Design. Now, it's iTeam is interprofessional training in empathy, affect, and humility, and mindfulness. And I put it right down there. It's an interprofessional, interdisciplinary program that engages participants in various learning experiences and workouts to cultivate skills and practices associated with empathy, humility, presence, well-being, and interpersonal communication. Right? So it is an individual level kind of engagement that also has team-based workouts and team-based communication-based skill building. And so we've had funding from a few foundations, and so we're building the modules now. We've actually have 3 done. We have 1 more to go, and it'll be ready to launch in April. So we're really excited about that. But this is the kind of idea of taking that notion of emotional contagion and being like, let's tap into that and the larger understanding of empathy, right? And then utilize that framework to help advance how we're teaching and how we're researching empathy within health professions and health professions education. Why do we use a workouts approach? Well, you wouldn't just go out and try to run a marathon, right? You wouldn't just like jump out there and be like, I can do it without any training, right? You can't do that. And you wouldn't just go out and squat 300 pounds. You have to build up to that. Now, I can't ever squat 300 pounds, but you get the idea, right? You want to build up to that weight before doing that stuff. So why do we expect health profession students and health professionals, we just toss them in there and say, be empathic. We know how good it is, so do it, right? Do this stuff without giving them any formal opportunities to really engage. Now, that's not to say there's not a lot of empathy training programs out there for health profession students to engage with, but they're not integrated throughout the curriculum over the years, right? They're not something that's embedded in the culture of healthcare delivery or within a lot of the health professions as it is. So why do we expect to have these empathic providers, these connected providers, if we don't provide them opportunities to build on those skills, right? So with effective training, we believe with effective training in the various facets of empathy, including emotional contagion, we believe it's possible to develop an empathic resilience in terms of building and strengthening those muscles, being less susceptible to secondary traumatic stress, compassion fatigue, negative side effects of others' pain and suffering through emotional sharing, while still engaging in authentic empathic connections and fostering connections with others, right? And then an ability to apply that authentic empathic experience to others, including patients and colleagues. So as I talked about, these are the muscles. And then here's some selected workouts that we have that we've included or nested within our iTeam program. These are not, this is not an exhaustive list by any means. These are some things that we do that, evidence-based practices that have been shown to kind of build these muscles in particular ways. And so we're really excited about it. I ran a program, there's actually a study, I forgot to put the link in here, where I ran this at UD with a number of health profession students, an in-person version. This was before COVID hit, before I moved out to Arizona. And we found that students did significantly increase in empathy ratings, and as well as other ratings, other positive attributes as well, and increase their knowledge of empathy and their desire to engage in more mindfulness practices throughout their education. So it did have an individual level as well as an organizational level, in that the University of Delaware was interested in kind of nesting the iTeam program throughout the curriculum. Whether they did it, I don't know, I left, so we'll see. One of the workouts, for example, is this listening exercise. I'm sure you have done this in so many other kind of things. It's the workouts that we have are not like new. They're not anything that would be blowing you away, being like, I've never tried this. These are things that we just kind of, we know do work. There's evidence, like I said, they're evidence-based practices, and there's a lot of studies and research behind them that show that they can engage the muscles that we want to work on. And this one is one, and you can share all these slides, it's recorded. So this is something I always have students do. I was telling Dr. Kelly earlier that I teach qualitative class, a lot of classes on qualitative methods. And I have students do this before they do anything else, in terms of practicing their ability to kind of sit and listen and giving the gift of attention to people they are interviewing or people they're working with. Now, the light lift on this is to do this with your friends and family. And I highly, highly recommend it. Right. I learned immediately I was a terrible listener, and I still have to practice this fairly regularly with my partner as well as with my colleagues, and really trying to give the gift of my attention for 3 minutes. You think 3 minutes is nothing. It is like hard to not want to interject. We're always trying to kind of put ourselves in the situation and kind of say our perspectives. We're always waiting to say what we want to say. So the goal of this, really, when you are playing the part of the listener, is to not interject. And it is not to even interject with like very few nods or very few ahas. It is to sit and listen. And it's a mindfulness practice in the fact that you need to be present with the speaker. You need, when you find your attention starting to drift, right, away from the speaker into something you're thinking about or something else, gently bring it back to the speaker and what they're talking about. And I've listed some possible topics that you can engage with as well. But try this at home. Try it. I mean, I love it. It's one of my favorite practices, but that's just an example of something that we bring into to really practice that notion of presence and awareness of self and other, and really be aware of some of this communication skills that we need to build and our connectivity with others. Real quickly, I'm my time here. I'm doing okay on time, it looks like. I wanted to bring up a little bit of work on PreMed specifically that I do, that I've done recently. And so a lot of the focus of my work has been on, especially at UD and a little bit here, has been on pre-meds, their experiences, challenges, especially inclusivity and belonging related to race and gender, as well as SES and major. So finding that a lot of students who go pre-med, of course, are still majoring in biology and chemistry, and a little bit of psychology too. That seems to be a rise. Not as many in sociology, and definitely not as many in humanities and arts. And so really looking at the pre-med path, looking at its structure and saying, okay, well, what are we doing? Because you know, AMA and AAMC talks about how they want all these, different types of majors involved. And yet, if you look at the actual path and the way it's built, and you look at the requirements, and then you add that on top of requirements for particular majors like sociology or let's say English, and compare that to the requirements of biology and how biology seems to match those requirements for most med schools, it's very interesting to say, do I want to have like 10 majors going through this and also do my shadowing and my volunteering? So there's a paper that we have, it's under review right now called Discriminatory Design, and it looks at how the pre-med path is an example of discriminatory design based upon looking at majors, particular majors, as well as issues of race and SES, and how, you know, you hear all the time that they want inclusivity and diversity in the health profession fields, but not really doing a whole hell of a lot structurally to open those gates up and really be more engaging with students. The whole paper on that. So that's a whole nother talk. Anyway, so that's where some of the work has the antiquity on requirements, admission structure, interpersonal, other attributes, things that I research in that area. Here's a few pieces in the kind of health profession realm, just a few select pieces. The reason I selected these just to put the covers on there was because these are, from my perspective, those are really exciting like topics to talk about. So like learning to cure, but learning to care is all about learning about kind of the socio-emotional qualities within med school. It's really, I thought it was really exciting. The stuff about interprofessional intervention in the MICU and the MICU and the ED, really exciting stuff. I found it fascinating to do that project. And then the whole thing on the hidden curriculum and the weaponization of professionalism, very exciting. So boring in the nature that they're presented in terms of like a journal article. Like I wouldn't want to read that as an undergrad or grad. Like I promise they're fun, but you wouldn't get that from that. So I decided to take a different path with a recent project and decided to team up with a colleague of mine that was in the art and design department over at Delaware. And so what we did initially through one of our projects, so I talked about the discriminatory design piece. This particular piece that I'm showing you here is just a few snippets. We wrote kind of a preamble to that piece that was picked up, that was written in kind of graphic medicine, graphic art form. It's a whole new genre called graphic medicine. That's not a new genre. It's been around about 20, 30, 40 years. But we utilize that genre to present some of a project on where humanism is in the pre-med realm. Where are aspects, elements, situations, experiences of humanism in which, you know, pre-meds were talking about how they are growing or losing their aspects of humanism. And so I put the link there. It should be open access. I think it is. If not, email me, I'll send it to you. But it gives you kind of I was much more interested in presenting this cool research in a way that I was like, well, at least people will like, at least visually, it's a little bit more intriguing. And so I'm hoping that there's ways in which we can find better ways to present our research that are a little bit more engaging with all audiences. And I'm not saying we have to bring it to a comic book form, all of them, but we do have to think about how we're translating our research to a broader audience that may not be so familiar with the kind of the structure of our general empirical pieces that we're required to kind of present or put our work into. And I think a lot of that comes from my sociology background. Like, you know, this stuff doesn't exist in a vacuum. So why do we write like it does? Like that's the thing. I don't get it. And Dr. Kelly knows I always had this thing of like, so what? Like, what am I doing any of this for? Like, what do I write about empathy for? Like, what's the point? Like, who is it helping? And that's always my big thing within my work and within my teaching is, okay, so what impact or reach does this have? And is it doing what it needs to be doing? Am I making sure that I'm not just existing in an echo chamber of other people who are really interested in this stuff? I don't want to be adding to a conversation. I want to hit different things. So I've had really great opportunities. Sociology has really provided me with so many doors. I've been an associate dean at UD, you know, a professor, the head of the pre-med evaluation committee, a number of other roles. You know, here at ASU, I'm in a nursing college now, oddly enough, and then I'm, you know, also a director of a center. So it's really been fantastic. I think sociology really allows, as some of you, all of you know who are on this thing, you know, really takes the fundamental knowledge regarding key issues. Like you think about the news today, and I don't know if you all do this, but people will ask me questions about kind of social, cultural, social, political things. And like, they're like, you know, they'll bring up issues like institutional racism. I'm like, how do you not know this? How is this not ingrained in your brain that this is fact? Like, I don't get it. Like, so it's hard for me sometimes to have conversations with friends and family who don't come from that kind of background or that understanding or get that factness of it and are somehow like, well, this isn't real. I don't see it. It's like, oh my God. So, but I feel like sociology is kind of like ruined, like understanding life. You see behind the curtain every day, and it's beautiful and it's awesome. It also makes you really you got to find that rage you might feel. You had to find a way to hone that into something productive, in terms of your writing and kind of your presentation, stuff like that. Makes it familiar and strange, of course, right? That's the key. That's the key of all sociology, is really saying, why do we do this? What's the point? Why are these things existing in this way? And also serves as a bridge to so many other disciplines. So getting involved in the arts, getting involved in humanities, getting involved in kind of the biological sciences and engineering, sociology is just perfect for that. So with that, I want to make sure I leave plenty of time for any questions. There may not be any, that's totally fine. But I wanted to open the doors for any. So thank you so much. I hope this wasn't too in your face. And if there's any questions now or later, I've left my email on there as well. So thank you.
Thank you so much, Dr. Michalec. I mean, that was fantastic. I so definitely want to open up the floor for questions. For those of you, you are welcome to put the hand raise app, or you can also do the or the app, the emoji, or you can drop a question in the chat and we'll be happy to bring those up. I am also putting the link in the chat again for the sign-in sheet if you have not already done so. And just a couple of things that I wanted to touch on there at the end. That discussion of the so what is something that I hear in my head all of the time, and not just when I'm thinking about my own research, but also thinking about the assignments that I assign for students. So for those of you that are in my 302 class and working on your op-eds, you just turned in, most of you turned in your drafts pretty recently. Again, same type of thing. How are we bringing this information out? Thank you. I've been doing it for a few years now, and it goes great. Fairly well. For 475, for those of you that are doing your creative term projects, a similar type of thing. How can we take this information and make it accessible outside of just the academy, outside of just these papers? And then 102, as you are working on your outside events, pieces, how can you connect this these discussions to to what it is that you are learning in class? How can sociology help to inform what you are seeing in the outside world, especially as related to health? So hopefully, that awesome. Conclusion, conclusion that you gave, I was like, yes. So yes. So what questions are out there? I hope that there are some things that were interesting to you, and if not, I can certainly have a few questions as well, but I'll open up to the students. Let's see. Yeah, Natalie, you can unmute and ask.
Oh, hi. So I just wanted to ask how, I feel like it's hard, especially, I guess, in the pre-medical sense, to think about, because I remember, you were talking about one time how, there's kind of an association, a negative one, with being empathetic and having emotions. So, I guess, how, for example, think of it in a clinical situation, right? So I feel like there would be what's the word? A counter argument. Sorry, I'm literally.
No, it's okay.
Where it would be well, wouldn't your emotions that you're feeling towards a situation impede your decision making process or how effective you are? So I guess I was wondering what your response to that would be, because for example, one of the reasons why I am pre-med is I think I'm very empathetic. I think that, I don't know what's the word, I'm an empath.
Yeah.
So I feel things very strongly and I really
Yeah.
want to like help others, but sometimes I worry like, wait, is that a bad thing?
Yeah.
So
No, yeah, no, great question. So a couple things. So one is it's not a bad thing. Number one, that it won't hurt you. And that again, the idea of having that concern does show you how powerful even kind of this pre-socialization, this anticipatory socialization is. The idea of, I feel very connected with others in this way, or I feel like I have a heightened ability or desire even to connect with others in this level. Is that going to be detrimental to me on emotional or physiological way when I get there? Even the thoughts of those concerns show you how pressing that culture is. Those aspects of kind of healthcare culture are that you're already feeling that, ooh, this could be something that may not be great. So that's really interesting. And studies do show that students do lose their degrees of empathy as early as the first year, medical students. So Hojit had a really kind of seminal piece that showed it happen in the third year. And then there's been a few others after that have shown that it's happened, when the students start to see patients. But there's been other studies that have shown it actually happens in the first, as early, even in the preclinical level. So there's levels, there's kind of aspects of socialization and professionalization happening that soon. That'll happen. The thought is that happens because of exactly what you're talking about. It's the idea that there's a shedding of empathy because I can't deal with all these stressors. I'm gonna jettison what may not be necessary for me to succeed in that way. So that's one way. Another way is to actually kind of harden oneself to kind of lose that, to actually be able to approach and not be vulnerable to others in that way. And so there's a number of processes that happen along the way that actually encourage that. The argument is that could lead to long-term issues in terms of emotional exhaustion and higher levels of burnout in general. So to get back to one of your original questions is, the counter of the actual, the possible negative side effects of connecting with others emotionally in that way consistently could be detrimental. And the point is that we need to understand better. There haven't been enough studies to show that if emotional contagion actually negatively impacts clinical reasoning. And so a buddy of mine from UD who's now at FAU, Chad Forbes, his work's fantastic. If you're ever interested in bias and issues related to race and gender and kind of those overarching implicit stereotypes and stereotype threat, Chad Forbes' work, off the charts, awesome stuff. Neuropsychologist. Anyway, he and I had put forth a grant application to study this, to say, okay, let's look at if this actually happens, because there's no evidence to suggest that that emotional contagion actually negatively impacts clinical decision-making and clinical reasoning. So that needs to happen. And that's what we framed, that paper I was talking about that just got accepted. We framed that study up to say, okay, let's go do that next. Let's see if that actually happens, because we don't know. And so we're hypothesizing that no, it doesn't. And that we think that if we can train those muscles associated with emotional contagion and empathy, that we might actually build that empathic resilience so that we can engage on that level and not be overwhelmed, not be overcome, and be able to authentically engage in the meantime. So it's interesting. So hopefully that answered your question a little bit.
Yeah, no, thank you.
It's just assumed that that's the case.
Yes.
And then that's taught that that's the case, but there's no evidence there.
Okay. I have a follow-up, but I know other people have questions, so I can let them go first.
I should say there's minimal evidence. Never say there's no evidence, because there's always something out there, right? Minimal evidence. Okay, there we go.
Okay, great. Thank you so much. And I mean, I think we can just go into the so we don't break the concept. But yeah, your follow-up question, I would be okay with that.
So kind of going, so this is kind of like now towards the other end, based on just like some personal experience I had. I was working in this company, it's called Our Family Friends. So I was working with elderly people, and like, so something that I noticed was that in addition to like providing them with just like very basic care, like for example, you know, like helping them walk, helping them like prepare meals for them, is that they also needed like substantial like emotional support, because a lot of times they were like, I don't know, I don't want to say abandoned, but like put in like facilities by their families, and so they felt very distraught. Or so, and for me, regularly spoke with one of the, I think, like managers of the company about how like it felt like they needed, like the patients needed more than what we could like, or what we were allowed to provide. And so it was very like draining on me, especially because we were very short staffed. So I guess like I don't see this, there's like nothing for this, I feel like. But if you are, you know, able to be empathetic, how can you like in a healthy way kind of like be in the middle, like not be completely like hardened and not feel anything, but also not be so emotionally distraught that it negatively impacts you. Like I feel like there should be something for this, like whether it be in the medical school curriculum, or honestly even just as an individual, as a person, to tell you how to like cope with that, because I feel like that's essential. And if we were going to like try to stray away from like not feeling anything, because I think it's just that it is like very burdensome, like maybe that's why people harden up, because they don't know how to cope with it. So I guess what would you suggest a solution? Or even like, I know you talked about, I forget the acronym.
The program I-Team. Yeah, so programs like that, again, like I-Team, there's I'm sure there's a few others out there that are really trying to do that. It's a way of providing opportunities to, you know, work out. I saw there's a question in the chat, and any question I don't get to tonight, and I'll stay on for however long questions go. I don't have to be anywhere. But if I don't get to a question, I'll answer it later via email. So there's programs out there that have these types of workouts to help build this idea of kind of, and I'm using the word resilience very lightly because I just don't like that term anymore, but it actually fits well with the notion of empathic resilience. And that's the idea of again, building a kind of an internal physiological internal response to others' emotional states that is authentic, but also allows you not to be overwhelmed and overcome by others' emotional states. We just don't, I think, as a nation, and then also specifically within health professional education, really do a good job of embracing the vulnerability of others as well as our own emotional states. We just don't do that. We really do pigeonhole emotions in vulnerability as negative in a very, and so we're taught that these emotions are negative. So the whole time you're like, oh, it's too much, I can't do it, because we're again socialized into understanding that that's burden, that's too much. And I think that if we start to reframe our perspectives on vulnerability and on interpersonal connectivity and on emotionality, that we actually will find ourselves in much better psychological, physiological, socio-emotional states to embrace others in that way. Again, I think one of the things that that is important to understand, that if this wasn't a good thing that we had, whether it was empathy or emotional contagion, we wouldn't have it. We'd be dead. Like if this was such a burdensome thing, that engaging with others in this way, it wouldn't be something that we would worked it out already, right? But we go through our daily lives being able to connect with others in this way. And it's actually, you know, next time, one of the things, another workout that I want you all to try to engage in if you have an opportunity, is be aware when this kind of phenomena happens. When you kind of catch someone else's emotional state, I want you to sit in it for a second, because again, it's innate, it's involuntary. We probably just pass it by 1,000 times. Sit in it for a second and just see how it feels, and embrace it for a little bit, and understand like that is something your body does for you. When you start to realize that capacity and that ability, I think it becomes less of an overwhelming of others' emotional states and more of a, how do I build this up, right? When you realize you can lift something, or that you can do something physically, it's kind of like, holy shit, like my body can do this, like this is amazing. That's what I want to start to look at in terms of the idea of emotional contagion. I think we just framed it in a way. So programs are really important in terms of gaining those workouts to bring it back to the fold, and consistent. Just like, you know, if you were going to kind of behavioral therapy or any type of therapy in general, you do it consistently, because that stuff actually helps you kind of reframe your cognitive mindsets and all this great stuff. So it's not something you just got to do one off. It's something you got to do consistent. Hopefully that helps a little bit with your answer. Okay, I'm trying not to talk around it, but talk in through it. But all right, cool.
Thank you so much. And we do have two questions that were dropped into the chat before Chris and Rowan's questions. So one is, I think, so the first one is, was your work on empathy qualitative? How did you measure a change in empathy? Very interesting work, by the way. And then the other question was talking. So I don't know if you, what answer
I'll do that one first,
so
and then I'll go, because I can see the other one too. Yeah.
Great.
So it was the quality. Yes, there was qualitative aspects to the work in terms of interviewing a subselect of the students to talk about, things they thought about the course in general, the program, but then also elements and they felt a shift in their empathic experience or their understanding of empathy. And so we did have some evidence there. The paper that came out, and again, I can share the link later on, was quantitative. It showcased the shift, the significant shift in empathy levels of the students. That part was quantitative, and that was using Davis's IRI, interpersonal reactivity index, which I felt was the more broad. Others agree that more broad approach to understanding empathy on a quantitative level. It's totally validated, totally reliable, all that good stuff. But we did try to get, and you bring up such a good point, because I had to make the same argument in the paper I was talking about, because the reviewer was like, you talk about doing this qualitatively, why is that important? And so you bring up a really key point, because it's essential to understand how these experiences are experienced and how they might change from the experiencer's point of view, and if they do, right? Because your empathy may be different than my empathy based upon various experiences. Your level of emotional contagion or awareness of emotional contagion might be very different, and your cognitive processes might be very different than mine. So how does that look like to the experiencer is essential. So really good point on that. Hopefully I answered that question. And I'm going to utilize more qualitative work as I move forward, even with my humility work. That's a whole nother thing. I know you talked a lot about workouts to improve empathy, but what ways would you recommend, or ways that have been observed, actually utilizing empathy to interact with patients and positively reinforcing clinical reasoning? Great, fantastic. So what we have found, like I shared those studies in the past that have been done in terms of showing that the patients who rated their providers in the various different health professions as more empathic actually had higher levels of satisfaction with their patient, higher levels of compliance, and had better mental and physical health outcomes in general. So in those sense, those studies do showcase that empathy has a positive impact on what you would say with clinical reasoning and in terms of clinical outcomes. So there is a lot of evidence out there to suggest that that is the case. How they're measuring empathy is a great question. They're usually utilizing various different types of measures for empathy in that sense. But that's it. In my own work, that's the next step, is to, take this broader theoretical framework of empathy that engages emotional contagion, and does it actually impact clinical reasoning in a negative way? The null hypothesis would be, I guess, from my perspective. We want to see if it has any impact at all on clinical reasoning. So you trigger emotional contagion, give them a generic clinical reasoning test that you all might take in your MCATs, something like that, or some kind of vignette study. We can utilize that as well, and then see if it actually has an impact in terms of actual outcomes. That's the next one. That's the next study. So we'll see. So it's kind of let's provide the evidence for that. Yeah. I think that was the last one I saw in the chat. So you can go ahead and call on anyone else.
Yeah, great. Chris, if you want to go next.
Thank you. So actually earlier today, I had the opportunity to look at your TEDx talk that was posted last fall, I believe.
Yeah.
And so that was really cool. And I just kind of had a question about that, as well as the talk that you gave tonight.
Yeah.
So basically, if you happen to know what the research kind of shows, or if there is any research out there about using this emotional contagion, this kind of honed power of empathy to relate to others without taking it, like internalizing it too much and kind of destroying yourself from those sometimes negative feelings that you might burden yourself with, like because you're emulating other people's opinion or feelings.
So right now we're doing a scoping review on the measurements of emotional contagion and how emotional contagion is triggered through various studies. What's really intriguing is that not a majority. I would say it's not a majority. It's a surprising amount of studies in this particular area on emotional contagion are done in animals, and specifically in rats and dogs and pigs. And so there is a lot of work that's happening in terms of emotional contagion in groups. So how do crowds share emotions? How does it pass through? So specifically like sporting events, in terms of a lot of that's preventative work to make sure that crowds aren't getting too rowdy and things like that. Because emotional contagion isn't just negative. Like all of us have looked at this in a negative way, right? We haven't thought about emotional contagion as a positive sense in this particular talk today, but that's exactly what happens too, is the positive sense. So emotional contagion is an innate, involuntary mechanism that it just is a catching to some extent of another's emotional state. And a lot of times the reason we know that it's not overly detrimental is because a lot of times folks just don't even know what's happening. They don't even acknowledge it. It's not even a thing to them. And so it's just kind of this mechanism that's within inside us that helps us connect with others, right? So that's how we know in terms of the research, and again, the scoping review will show that how it's triggered and stuff like that we know that it's not kind of, it's not attacking on of constant emotional states. You're not constantly like, oh God, I'm gonna hit again, right? Because you're not fully aware of the work that you're actually doing in that sense. That's why we know that it actually is more positive than a detrimental kind of mechanism within us. Does that help answer?
Yeah, thank you.
Great, thank you so much. And yeah, Robin, go.
Mine is kind of like more broad, like open-ended, like sight into the future. Cause I kind of like my whole life I've kind of been told, oh, you're too emotional to be a doctor. Like it's not gonna help you in the future, but yada yada yada. And let's say past the research and past like when you find, if you were to hypothetically find all this positive impact,
Yeah.
and you were to put it in, let's say like into the medical field, would it be kind of, you said there's the workouts, it can be taught, it can be this. Would it be like in the clinical, would it be like scenario based, or would it be like more academic, like understanding definite, like my question is very general.
No, I know what you're saying. I know what you're saying.
What it would be like, because that's something I'm really like interested in, because like literally my whole life everyone's like, you're way too emotional. I'm like, I feel like it can be taught in a way, but would it be like clinical, okay, like what to do in this situation, or like let me understand what's going on first and like applying it in that kind of sense?
Yeah, for sure. And Dr. Kelly, please step in, because I know you know some of this work as well, but there is efforts to kind of reintroduce emotions and interconnectivity into, I'm going to use medical education in general. So you'll see an influx, if you haven't already, of arts and humanities within your preclinical and sometimes clinical years. And the goal of these initiatives are primarily to reintegrate kind of the ability, it's not just observation abilities and kind of to hone clinical reasoning, it's also to really say, oh, we do care about emotions. We want you to connect in this way. We want you to deal with these tough decisions. And sometimes they'll nest them within ethics or something like that. But in general, it is more or less of a idea of connecting in this way with kind of the humanness. It's to increase the humanism within medicine, right? And you have the funders that I noted for iTeam. They're all about incorporating humanism back into medical education. So there are elements in existence that are trying to do this. So we know it's a good thing. We know that having physicians, let's say specifically, and medical students that can connect in this way and are not overwhelmed, but also like utilize kind of emotional intelligence, we'll frame it as that, as a way to kind of better patient outcomes and better themselves and better their colleagues, are beneficial. So that's why you see the influx of these types of programs peppered throughout medical education and professional medicine. For us, our goal really is to provide a program, because it's an online learning modules, provide a program that med students, pre-meds, professional physicians could all take, and we have continuing ed credits attached to it, so they're encouraged. But then also take those notions, take those ideas, and kind of cultivate agents of cultural change and say, look, oh, this isn't so bad. This is something that we can actually do. This is something we can lean into. This is something that we can actually engage with. So it's kind of a, let's put it into the system at that meso level. Let's create agents of cultural change at that micro level. And let's see if we can then impact leadership and impact kind of the overarching culture of organizations and the institution of medicine to have that kind of trickle down effect in terms of that macro level. So it's a multi-pronged approach, but what you're trying to do is really like you're batting your head against a wall of like a gazillion years of an organization that has not had to change. I mean, it's just, so you just got to keep on going at it, and it's bit by bit. So, but don't, yeah, for all of you who are on this, who feel like you might have a higher level of emotionality than others, that's cool. Like that's going to serve you well. And if you don't, that's cool too. Try to look out for the things within your health professions education that may be trying to implicitly and explicitly knock that out of you, because that's what's happening. That's what we're finding is the problem. So that's the issue. So you don't worry about it. They'll find a way, but we're trying to put it back in. Okay. I saw another thing in the chat. Is there some sort of scale that may rate the severity of emotional contagion, something similar to what? Yeah, severity in terms of, there's a couple emotional contagion scales. So you can just Google emotional contagion scale and you'll come up with a couple. Some are better than others. In terms of severity, I'm going to hesitate to say, is the question about severity in terms of like how hard you caught someone else's emotion, because that's a challenge. That would be a kind of a physiological study in terms of your heart rate increasing, certain other physiological mechanisms triggering based upon that emotional kind of catching of another's emotional state. Those are the studies that we're looking at now in terms of what feelings are okay. Is that a hashtag for this? That's great. If it's not, if it's a real hashtag, that's awesome too.
No, I just made it.
Oh, I love it. So there are a number of scales. That's the answer to the question. In terms of the severity of a catching, yeah, trigger, yeah. Those studies are out there, and so you can go on Google Scholar, find them. And again, like we're trying to work on compiling how they're measuring that. That's exactly what we're trying to do now, because there has not been. There is a small one. I will find it actually, and Dr. Kelly, I will send it to you as a link. There's a small one that our review picked up, and it happened recently, but it's not great. So it's kind of like, oh, our scoping review would be better. But this one it might help in the initial short term. So I'll send that to you. But it's fascinating, like this idea of that physiological responses to emotional contagion. That's exactly what we're fascinated about, and wanting to kind of put all into one big thing and be like, look at all this work, whether it's humans, whether it's primates, whether it's other animals, like they've been doing this work, and what triggers it? What are some things? We know that with empathy, the closer you are in terms of relation, the less social distance, the higher the likelihood of experiencing empathy with somebody else. And so we can probably assume that emotional contagion is somewhat similar. The closer in our in-group, our friends, family, people that we know very well, more than likely we're going to have a higher physiological response to that emotional contagion with them than kind of a random other. And you can look at that in terms of race, gender, ethnicity, SES more than likely as well. Those types of things, probably the same kind of thing, but that's what we want to show. Be like, hey, what are the themes here in the research? And we also want to, one of the big things for us, and I'm taking everyone's time and I apologize, but one of the big things for us at CAIPER is to decrease, or I should say increase that in-group. So we want health professions and health profession students to increase their in-group, so they see others as part of their group, whether they're nursing students, med students, PT students, OT, social work. We want them to increase and create a common in-group identity, or kind of really focus on that personalization approach to saying, hey, you're not just, the nurse, you are John. You have this life, like understanding that we're putting people more on this human level. And that's what we're trying to do with empathy, emotional contagion, humility, that kind of stuff, is bring it all to a fundamental human level, that where everyone exists on a kind of a similar playing field. And it's not really accentuating, what roles you play in the clinical setting. It's accentuating the humanness of each other and how you can all interact with each other and show and respect the values, the knowledge, the abilities of each of the other health professions. And we hope that starts early on. That's why we focus on kind of students in the pre-professional and kind of professional realm. So with that, I'll stop there. I'll write down to get you that second.
Yeah, thank you. Thank you so much. These have been some really fantastic questions. Dr. Michalec, you said that you had a little bit more time. I don't know if there are any other questions that anyone has right now for those who are still here, and you can always, Dr. Michalec did put up his email within that, and or I can always forward questions to him directly as well. But does anyone else have anything that they want to ask Dr. Michalec while we have him here? Thank you.
Mm-hmm.
All right, so if we don't see anything else, I guess we can wrap it up there. I thank you so much again for sharing your work and your knowledge with us. I'm very much, very excited to see these new papers that you have coming out. So yeah, really very much appreciate it. And as that is all I have for you. So everyone that is still here, again, thank you so much for staying through to the end. And I'm happy to answer any additional questions or pass on additional questions to Dr. Michalec if you have them.
Thank you all so much. Dr. Kelly, I'll send you those links. And then if anyone has any questions, feel free to email me otherwise. But thank you so much for the time and thinking about this stuff in this way. I know it's a little bit different, so I appreciate it.
Awesome. Thank you. Have a wonderful night.
Bye-bye, y'all.